Okay, so I think we'll make a start. So welcome to the IDSOC X MedEd ID crash course covering infections by systems. So we've already done session one now, and then session two is going to cover gum, urology, HIV and opportunistic infections, and pediatric infections as well. So we hope it's very high yield and helpful for the upcoming progress tests, and also if anyone's in fifth year, it should be helpful for finals as well. We've tried to base things off the UKMLA map. We have got a feedback form, so if you want to fill in the feedback form, if you need to leave early, as long as you fill it in, we'll have your email so we can send you the slides. And again, it's helpful if it's interactive. We've got some questions in the session, so if anyone wants to answer any questions or ask any questions, then please pop them in the chat. The session should take around 2 hours, but it might overrun. Hopefully, fingers crossed it won't. But if it does, then fill in the feedback form and you can get the slides as well. So I'll introduce Kitty, who will start with gum.
Okay, hi everyone. So I'm going to be doing the genitourinary medicine side of the ID crash course that we're doing. I'm not going to be able to see the chat while I'm doing this, so if anybody has any questions, then please just put them in the chat and I'll answer them after. So in this session, I'm going to be covering syphilis, chlamydia, gonorrhea, pelvic inflammatory disease, bacterial vaginosis, trichomonas, HSV, epididymolycitis, and HPV as well. So starting with syphilis, so the transmission of syphilis, so it's sexual contact, and I'm going to just use the phrase sexual contact throughout this presentation, but you can elicit this by, as a doctor, taking very thorough sexual history, and another form of transmission of syphilis is mother to baby, so vertical transmission, IV drug use and blood transfusions as well. There's a very large range in incubation period of syphilis, so 9 to 90 days. And there are kind of three main stages of syphilis. So there's primary, which is a painous chancre, so a painous ulcer at the site of infection. And this can be quite difficult to visualize in women. And when I say women, I mean assigned female at birth. And when I say men, I mean assigned male at birth, just for means of time. It can be internal, so it's difficult to visualize. And you can also get non-tender local lymphadenopathy. Secondary syphilis is characterized by a maculopapular rash of the trunk, palms, and soles, mucosal ulcers, condylomata lata, which is white and grey, warty lesions of the perineum, and other systemic symptoms like fever and weight loss. And then tertiary syphilis, which is very rare in the UK this time period, but it's known as the great imitator, so it can impact any organ system. So you can get granulomas or gummas of the skin and bones, like breaking down bones, aortic aneurysms, neuropsychiatric problems, and an Argyle Robinson pupil, which is where you only get pupillary constriction to the accommodation reflex, not to light. That's an exam favourite, they love asking that. And investigations wise, this is where a lot of people get confused. So you have a trichomonal test, which looks at whether or not you have an antibody to syphilis. So it will be positive whether or not you have the infection or you've cleared it. So once you have syphilis, that will be positive for the rest of your life. And then, so that's done for diagnostic reasons. And then a non-trichomonal test, so your RPR and VDRL, they measure disease activity. So they look at how you've responded to treatment. So the higher that is, the more reactive you are in disease. It is not very sensitive though, so you can get quite a lot of false positives. It can be triggered by things like HIV and TB, even pregnancy. So that's an important thing to bear in mind. And treatment wise, it's a stat dose of IV benzoyl penicillin. So yeah, that's what I've got to say about syphilis. And then chlamydia, again, the transmission is sexual contact and very rarely transmission from mother to baby during birth. it's asymptomatic in about 70% of women, so a significant proportion in 50% of men. But with symptoms in women, you can get cervicitis, dysuria, dyspareunia, and pelvic pain, and abnormal vaginal bleeding, so instrumental or postcoital. And in men, you can get urethral discharge, dysuria, and epididymolysis. In examination findings, you can get lower abdominal pain, cervical excitation, cervicitis, and purulent discharge. So investigations are a nucleic acid amplification test. Again, they also really like asking about this. So in women, it tends to be a vulvovaginal swab, and in men, a first catch urine. And the treatment for uncomplicated chlamydia is doxycycline 100 milligrams twice a day for 7 days. And complications are general pelvic inflammation, pelvic inflammatory disease, which I'll go on to speak about later. And a rare but serious complication is lymphogranuloma venereum, which is, it has 3 stages. It starts as kind of like painful inguinal lymphadenopathy, and it can form kind of bulbo ulcers and pustule things, and it can cause chronic, and in its final stage, it can cause chronic proctitis and genital and rectal malformation complications. But again, quite rare these days, but it's important to be aware of. Chlamydia is also associated with reactive arthritis as well, which is an important one to remember. If you have somebody come in with the whole I can't see, can't pee, can't climb a tree. And moving on to gonorrhea. So transmission, again, is sexual contact and vertical transmission, and it's much more likely to be symptomatic than chlamydia, with 90% of men showing symptoms and 50% of women being symptomatic. And in both men and women, you can get odorless, purulent discharge, green, yellow in colour, and dysuria. And in men, sometimes you can get testicular swelling as well. Diagnosis, very similar to chlamydia, it's just a nucleic acid amplification test. And the treatment tends to be intramuscular ceftriaxone, 1 gram stat, just 1 dose. But if they're needle, there are other options if people don't want to use needles. And complications of these in women, pelvic inflammatory disease, and men, epididymolysis. And with vertical transmissions, you can get ophthalmoma neonatorum, which is conjunctivitis with discharge within 21 days of birth of a fetus. Again, good to know. And then you can get a disseminated gonococcal infection, which causes dermatitis, a very itchy rash, and migratory arthritis, so arthritis moving from joint to joints, and it can also cause quite high fevers as well. And moving on to pelvic inflammatory disease, so it's a term used to describe an ascending infection and inflammation of the female pelvic organs, and the most common causative organisms are chlamydia and gonorrhea. But they can also be exacerbated by Mycoplasma genitalium and Mycoplasma hominis, which exist in the female reproductive tract normally, but overgrowth can impact the development of PID. I've realised I haven't actually put the symptoms of it, so I'll just go through that very quickly. So the typical symptoms of PID is deep dyspareunia and lower abdominal pain with cervical motion tenderness, adnexal tenderness, and it can also come with a high fever as well. So that's kind of like the traditional presentation. You also think about risk factors like previous sexually transmitted infections or previous PID, important to know. And investigations, you need to look at inflammatory markers, so CRP, ESR, because they can be raised. I think with somebody coming in with lower abdominal pain and adnexal tenderness, you need to always do a pregnancy test and rule out things like ovarian torsion or cysts. But then also testing for causative organisms is important as well. And the management of PID is intramuscular ceftriaxone, one dose, and then 14 days of oral doxycycline and oral metronidazole. And with IUDs, when an IUD is first inserted, there's an increased risk for the first 20 days of developing PID, but then it goes back down to normal. And in severe pelvic inflammatory disease, it can be suggested that it's removed, but usually it's okay. So the complications of PID, so the typical one that they like to bring up in exams is Fitzhugh-Curtis syndrome, which is perihepatitis, so inflammation of the lining of the liver, and it can cause right upper quadrant pain radiating to the back, shoulder pain, and you can hear a hepatic rub sometimes on auscultation, and it's got the typical sign of, on laparoscopic investigation, you can see these like violin string adhesions from the abdominal wall to the liver. And PID can also cause infertility. So each incidence of PID, there's a 10 to 20% risk of developing infertility. It can also cause appendicitis as well, and ovarian fallopian tube abscesses as well. And it can increase your risk of like developing chronic pelvic pain and future ectopic pregnancies. So that's all I've got to say. And then bacterial vaginosis. So this is one of the ones that's not strictly an STI, but it can be exacerbated by sexual activity. So it's an overgrowth of predominantly anaerobic organisms like Gardnerella vaginalis. So features are thin white fishy vaginal discharge, but 50% of women are asymptomatic. And then you've got the Amstel criteria, which is the diagnostic criteria for BV, which takes into consideration thin white discharge, clue cells on microscopy, a pH above 4.5, and the positive whiff test, which is less commonly used now in practice. It's the addition of potassium hydroxide, and it produces an unpleasant odour, but it's not really used anymore. And management, so if you're asymptomatic, it's usually there's no indication to treat unless it's before a termination of pregnancy, because you could be at increased risk of post-operative infections. And if you are symptomatic, then oral, or if a patient is symptomatic, then you can take oral metronidazole for 5 to 7 days. It's treated in pregnancy as well because it carries a risk of preterm labour. But again, avoiding single high dose of oral metronidazole. Okay, so moving on to Trichomonas vaginalis. So the features of this are offensive yellow-green frothy discharge, vulvovaginitis, and buzzword, the strawberry cervix. And again, pH of over 4.5. Men can actually carry this as well, but they're often asymptomatic, but it can cause urethritis. The gold standard is an AAT test, but you can do a wet mount slide and look for motile trophocytes. And the management is also oral metronidazole for 5 to 7 days. You can be given a stat dose, but this should be avoided in pregnancy. So I've just got, we decided not to do candidiasis in this session, but this is just a table to refer back to that compares 3 conditions that are very often confused and got very similar presentations. So I've just got that to refer back to for when you get the slides after the session. And then moving on to HSV, so herpes simplex virus. So you've got 2 main types that cause ulcers. So you've got HSV1, which is associated with cold sores and genital herpes, and HSV2, which is associated with genital herpes. So, but we have an understanding that there is a lot more crossover between those 2, and the transmission is direct contact with an active ulcer or asymptomatic shedding. So if before people develop the ulcer, they are infectious, and that is called asymptomatic shedding. And the herpes simplex virus lives in a ganglia, so it can't be cleared. So latency usually is in the trigeminal ganglia or the sacral ganglia. So the features of it are the painful genital ulcers, tingling, burning sensation, dysuria, and inguinal lymphadenopathy. Primary episode tends to be the worst, and then repeated recurrences are much milder. Diagnosis is predominantly clinical, but if there's any insecurity or unsure, if you're unsure about the diagnosis, then you can do a PCR swab as well. And with the management, it's oral acyclovir and recommended abstinence during outbreaks. Pregnancy, there's quite a severe risk of neonatal herpes. So if you have a primary outbreak, first ever outbreak of genital herpes before 28 weeks, you're treated with acyclovir and you're given prophylactic from 36 weeks. And then if you get a primary outbreak after 28 weeks, you treat that, you give prophylaxis past 36 weeks, and also you suggest a C-section as well. And if it's a recurrent outbreak, then you have a much lower risk of transmission, but you should still be given prophylactic treatment from 36 weeks. And then moving on to epididymoorchitis. So the causes of this tends to be in those under 35. It tends to be more likely to be sexually transmitted infections, so chlamydia and gonorrhea. But again, it completely depends on how many sexual partners, and it doesn't really matter what the age is, of course, but it tends to be what they say in exams. And if they're above 35, you consider things like enteric causes like E. coli, and mumps can cause epididymoorchitis, but that's more of like a paediatric presentation. And the features are unilateral gradual testicular pain, tenderness, swelling, a dragging sensation, and discharge if the STI is present. And you can get significant fever and systemic symptoms as well. And it's obviously important if you're getting a unilateral testicular swelling to exclude torsion, because they can look quite similar. Investigations are testing for the organisms if you are suspecting an STI, a urine MCNS, and scrotal ultrasound if you're unsure of the diagnosis. If the STI is likely, you kind of treat quite broadly, so ceftriaxone and doxycycline. And if you think if it's E. coli or an enteric cause, then ofloxacin, levofloxacin, and comoxiclav, and then supportive treatment, analgesia. And then complications of this is untreated. It can cause chronic pain, testicular atrophy, and scrotal abscesses in some as well. And then HPV, there's a lot to say about HPV. I'm going to focus mainly on genital warts. A very common STI type. Type 6 and 11 are associated with genital warts, and then 16 and 18 are genital cancers. So transmission is skin-to-skin sexual contact, and it can be transmitted without there being an active wart or lesion. And they're usually painless. They can potentially cause itching and discomfort. They're usually soft, flesh-coloured, and it's a clinical diagnosis, so there's no HPV testing for warts in the same way that you have with like cervical screens, that kind of thing. And there are topical treatments that you can use, and if they fail to work, you can use cryotherapy, especially if they're particularly bothersome, and do multiple sessions of cryotherapy. And the HPV vaccine protects against the same strands that cause genital warts. So that's the main preventive measure, but also barrier contraception, safe sex practices. And this is quite an overwhelming slide, but again, it's from the British Association of HIV and Sexual Health, and they love asking about swabs and where to take them and what type of assay to use. So I've just put this in there to refer back to, and it has all of the information on whether or not you should to swab or not to swab. And with all of these I've mentioned, there's no legal requirement to inform partners, but you should strongly recommend and provide information about discreet telling of partners. So this is what you should say if people ask. So if chlamydia, all partners within the past 60 days, if they are symptomatic, or 6 months if they're asymptomatic. Gonorrhea, if they're symptomatic, partners in the last 2 weeks, and if asymptomatic, then 3 months. Syphilis, if you've got primary, past 3 months, and secondary, past 2 years, and then tertiary, lifetime partners. And then with trichomonas vaginalis, all partners in the past 4 weeks, and it's a bit more blurred with HSV and HPV. You should encourage people to tell partners, but they can be latent for a very long period of time, so it's difficult to pin that down specifically. And as much as this isn't used in practice anymore, or when it can be, they still really like to ask these in like multiple choice questions. So these are just kind of like some buzzwords and things to look out for. So gram-negative diplococci is gonorrhea, and I've got that in the first picture. And then clue cells, which is bacterial vaginosis, which is seen on microscopy. And then trichomonas, you have motile flagellated protozoa, so you can see them moving on a wet mount slide. And then you get budding yeast and pseudohyphae in Canada as well. Thank you. Has anybody got any questions?
Thank you, Kitty. That was really good. So there's no questions in the chat. So if Anita, you want to share your slides, and we'll go into urology. And if anyone's got any questions at all, then pop them in the chat, and I'll do my best to answer them.
Well, okay. Hello, everyone. My name's Anita. I'll be talking through the urological conditions. Just bear with me one moment. Real. Can everybody see my slides?
I can't personally, but I might be alone in that.
Oh,
Okay, I can see them now.
yeah, you can see the PowerPoint.
Yeah, you're not quite in presenter mode though. If you want, one of us can share slides if that helps you.
Sure. I don't know why it wouldn't be working. Let me try and share again. Have a little look. If it's not working now, then I might need one of you to help me share the slides.
Yeah, I don't mind sharing.
That's great. Thank you.
Second.
Thanks, guys. Yeah, we'll have one of us share now so that everyone can see.
That's fine. Thank you so much.
Okay, and then
And Lydia, I can keep an eye on the chat for you while you're sharing as well.
let me just go to Anita's slides. Can you see this?
I can, yeah.
Perfect. Let me know when you want to move on.
Real. Let me see actually if I can. No, okay, that's fine. Real. Okay, so we'll be going through the urological slides today. So we'll be mainly focusing on lower urinary tract infections, and we'll briefly talk about prostatitis. So you can go on to the next slide, Lydia. We'll briefly talk about prostatitis and pyelonephritis as well. And if we have time at the end, there are a few questions just to check people's knowledge. So in terms of the lower urinary, well, we'll talk about the urinary tract anatomy generally, because lower urinary tract infections affect your lower urinary tract, which includes your bladder and your urethra, whereas pyelonephritis will affect your kidneys and your ureters, which comprises your upper urinary tract. Lower UTIs are a lot more common, and upper UTIs tend to be more in serious infections with higher complications of sepsis and other complications down the line. So in terms of lower UTIs, the way that they usually present, or the way that they happen, is that bacteria will invade the urinary tract and then colonize the bladder and the urethra. This bacteria usually comes from the GI tract. So the most common pathogen is E. coli from the GI tract, and that will enter through the urethral opening or the meatus and then ascend up the tract to the bladder. Other pathogens that can cause UTIs are Staphylococcus aureus, Proteus, Klebsiella, but E. coli is by far the most common. Thank you, Lydia. You can go on. In terms of risk factors for UTIs, a big one is female anatomy because our urethras are shorter. So it's a lot easier for bacteria to colonize the bladder. Sexual activity also provides an opportunity for bacteria to enter the urinary tract. Poor hygiene, so wiping back to front. Catheterization, because the catheters can provide, again, a way for bacteria to enter from the environment into the urinary tract. Being postmenopausal, being pregnant, having an enlarged prostate, because when you have an enlarged prostate, it causes urinary obstruction, and that allows bacteria to basically fester inside the urinary tract once again. And then any structural abnormalities with your tract, so having any reflux, having any stones, all increases the risk as well. In terms of how they present, lower urinary tract infections usually cause dysuria, which is a stinging pain on urination, frequency, urgency, foul-smelling urine, cloudy urine, blood in the urine, and can also cause lower abdominal pain, specifically suprapubic pain, and in elderly patients, it might present with confusion as well. In terms of how we investigate it, first line is a urinary dipstick, and in some cases, you might have to send off that urine sample for microscopy and culture. In patients who have persistent symptoms or symptoms that aren't really responding to treatment, you might want to also investigate causes for why they're getting recurrent UTIs, so an ultrasound scan of the urinary tract or a cystoscopy to actually look inside the bladder. In terms of urinary dipstick interpretation, in UTIs, your dipstick might be positive for nitrites, and this is because gram-negative bacteria like E. coli convert nitrates in the urine to nitrites. You also might have some leukocytes or blood, and they can be suggestive of an infection. However, they are less specific because it can be caused by other pathology. In terms of how to interpret it, NICE guidelines say that if your urine is positive for nitrites, that makes a UTI very likely because it is quite specific. And if it's positive for leukocytes and blood, both of those, again, a UTI is likely. However, if it's negative for nitrites, but positive for leukocytes, a UTI could be possible, but also it can be caused by other pathology. And if it's negative for all three, then a UTI is very unlikely, and you should consider other causes for this patient's symptoms. It's important to know that dipsticks are not reliable in all groups of patients. So in patients over 65, it's common for elderly patients to have bacteria present in their urinary tract, and that might not be causing them symptoms. So even if they have positive bacteria, in the absence of infection, it's important to know that the dipstick might not actually be accurate. This is the same in pregnant patients, in patients who have catheters, and also patients who have a history of recurrent UTIs. If you send off a urine sample, this might be useful in patients where you want to confirm a diagnosis, so a UTI might be as likely as another pathology. And also it is quite useful in establishing sensitivities in patients to ensure that you're actually giving them antibiotics that will treat them. And the sample should be sent ideally before the antibiotic treatment is started, so they're as accurate as possible. In terms of how lower UTIs are managed within patients, it depends if a UTI is classified as uncomplicated or complicated. It's an important distinction because complicated UTIs have a much higher risk of treatment not working or having complications from their infections. So an uncomplicated UTI is a UTI in any non-pregnant woman who is otherwise healthy and has no other comorbidities. Whereas a complicated UTI applies to any patients who are pregnant, any men, because their urethras are a lot longer, and it's a lot harder for them to be infected. Any patients with a history of recurrent UTIs, many patients that have catheters in, Oh, so I can see that you and Lydia and Charlotte have their hands up. Is that?
Yeah, Anita, we just had a request in the chat if we can slow down just a tad for people.
Oh, sure.
Just trying to get everything in, I think.
Yeah,
But it's
that's
brilliant. You're doing brilliantly, so thank you.
It's a lot of information, so I'll try to slow down a little bit. So yeah, so in terms of what is classified as a complicated UTI, that's in any pregnant women, any men, because of a longer urethra that they have, any patients that have recurrent UTIs, patients with catheters, any patients that are immunocompromised, and anyone that has any abnormalities with the urinary tract. So again, any stones, any reflux, or any strictures that are affecting the tract. So the management of uncomplicated UTIs, which again is any non-pregnant women, is a 3-day antibiotic course. First-line antibiotics are nitrofurantoin or trimethoprim. And nitrofurantoin is usually used because in certain areas of the UK, there are higher rates of bacterial resistance to trimethoprim. And in terms of the uncomplicated UTIs, we'll kind of cover each population as we go. So with pregnant women, management is the same. Management is the same whether or not the patient has symptoms or not. So you would send off a urine sample for microscopy and culture, and they would be given a 7-day antibiotic course. And then at the end of the course, you would want to collect another urine sample to make sure that the infection has actually been treated. It's really important that in pregnant ladies, you treat any positive bacteria in urine, even if they don't have symptoms of a UTI infection, because it's been shown that untreated bacteriuria can cause pyelonephritis in the future, and in pregnancies there's a big risk of things like premature labor or affecting birth weight of the baby, so it's important to get that treated. In terms of antibiotics in pregnancy, some key things to know is that trimethoprim is contraindicated because it's a folate agonist, and obviously folate is needed for cell division and growth in the baby. Nitrofurantoin can be used, but it should be avoided near term. So in the last trimester, it should be avoided altogether because it increases the risk of something called hemolytic disease of a newborn. So if nitrofurantoin and trimethoprim both can't be used, second-line antibiotics include amoxicillin and cefalexin. With men, because they are classified again, it's really one quick note is that trimethoprim or nitrofurantoin even is contraindicated in patients that have really bad renal impairment as well. So in men, because it's a lot less common for them to get urinary infections, they tend to be a lot more susceptible to treatment failure, and so they need a longer course as well. So they're given 7 days, but their first-line antibiotics are the same as non-pregnant ladies, so nitrofurantoin and trimethoprim. But it's important to note that if you suspect that they have an infection of their prostate instead, you use different antibiotics because nitrofurantoin and trimethoprim don't actually treat prostatitis, but we'll talk about that a little bit later. Catheterized patients also require a 7-day course of antibiotics, and the catheter should also be changed just to prevent the infection from reoccurring. However, unlike pregnant ladies, if a catheterized patient has bacteria in their urine but doesn't have any symptoms, they don't actually need to be treated. So you only treat them as a UTI if they have burning sensation, urine infrequency, and urgency. In terms of complications that can occur with UTIs, obviously the infection can ascend up into the kidneys and cause pyelonephritis. You could also get a renal abscess, which is a collection of pus in your kidney. It could cause AKIs and also, in very severe situations, lead to sepsis. But these are basically all complications of if the infection travels up into the kidneys. I'll really briefly talk about prostatitis because it's not a super common infection. However, it's just really important. It's an important differential, specifically in men that have lower urinary tract symptoms, because It's not common, but if it does occur, it's quite serious. So in terms of differentiating between UTIs and prostatitis, usually the symptoms of prostatitis are worse, and prostatitis specifically causes pain in the perineum area and in the groins and the genitals. And in a lot of patients, they can also get painful ejaculation. So another another feature of prostatitis is they tend to have a tender prostate on a DRE. And that's, again, just an important way to differentiate between the two conditions. This is clinically important because prostatitis needs a much longer antibiotic course. So they usually need 14 days and also will need different types of antibiotics. So nitrofurantoin and trimethoprim have both been shown to be ineffective in treating prostatitis. So the first line is usually a quinolone, like ciprofloxacin, or a cephalosporin, like ceftriaxone. And just really briefly, we'll talk about pyelonephritis as well. So that's an infection of the kidneys. And risk factors for pyelonephritis are very similar to UTIs, so female sex, being pregnant, being catheterized, having anything that will obstruct your urinary flow, and also being immunocompromised. And the most common pathogen that causes it, again, is E. coli. In terms of how it presents, the classic triad that you'll see in exam questions is a patient with a fever, flank pain, and also nausea and vomiting. So it's a lot more likely to cause constitutional symptoms compared to a lower UTI. Other symptoms include blood in the urine, foul-smelling urine, having flu-like symptoms in general, malaise, and also confusion. And also it can cause diarrhea as well in some patients. So the reason that quinolones and cephalosporins are preferred in prostatitis specifically is because, so I was just answering a question in the chat, is just because it's been shown that nitrofurantoin and trimethoprim, for whatever reason, they don't reach high enough levels in the blood to effectively treat a prostate. They just don't reach the prostate to a high enough concentration, essentially, to kill the bacteria within the prostate, if that makes sense. I'll just continue talking about the presentation of pyelonephritis. So it usually presents with costovertebral angle tenderness, which is the same as renal angle tenderness, which you can see on this picture here. And in terms of sepsis, or in cases of sepsis where the infection reaches the bloodstream, you might see pale, cold, clammy skin, hypertension, tachycardia, and also reduced urine output. In terms of investigations, it's important to note that it's usually a urine sample that's collected. Urine dipsticks are usually not used in diagnosis of pyelonephritis because they have limited accuracy and reliability. And again, it's important to collect the sample before you start with antibiotics to make sure that you have the highest chance of actually growing the bacteria and having an accurate sample. Blood cultures might also be collected in patients that are systematically unwell and requiring hospital admission. And also with any infection, you want to order basic blood tests like FBCs, which will show a raised white blood cell count, and also raised CRP as well. And that's just a note about how urine dipsticks are not reliable. So in terms of the management of pyelonephritis, it does depend on if a patient is stable enough to be managed in community or if they need to be admitted to hospital. So if a patient is stable enough to be managed at home, then they can have an oral antibiotic course, usually 7 to 10 days, and cephalosporins like cefalexin are first line. And other antibiotics can be given if the culture shows that the bacteria is sensitive, so coamoxiclav or trimethoprim. And you can also use quinolones like ciprofloxacin. However, they're usually not preferred because quinolones have a rare side effect, but quite an important side effect of increasing tendon damage. So they can increase the risk of specifically Achilles tendon rupture and damage, which is, again, it's a rare side effect, but it does come up in exam questions, and it is important to know because that's also a contraindication to giving these antibiotics. In terms of, sorry, Lydia, you can go on to the next slide. In terms of if a patient needs to be admitted to hospital, there are nice guidelines that kind of help you gauge clinically if a patient will need hospital admission. So if there are any signs of sepsis, if the patient is pregnant, if the patient has had 48 hours of antibiotics at home and is not improving, if they're very dehydrated or they're not able to maintain the hydration through fluids or can't take any medications orally, they also need to be admitted for IV treatment. If they have higher risk of complications because they're immunocompromised, they have diabetes, or they have an actual structural abnormality of their urinary tract, these are all indications of admitting them to hospital. And in hospital, they'll have IV treatment, so they'll have IV antibiotics, and maybe later down be step 2, oral. They'll also need IV fluids for dehydration, any painkillers, and also any antiemetics. So you're just trying to treat the symptoms that they have. And the complications for pyelonephritis on the next slide are just very similar to UTIs. So they can cause urosepsis, AKIs, abscesses, and also in the case of pregnancy, increases the risk of premature labor. So those are those 3 conditions in a nutshell. I don't know if we have time for questions, but just
Yeah, I think we've got time for questions.
I might do it as a poll, like a poll in the group chat, just to make it a bit quicker. And I'll just give it like a few seconds for each question, just so we're not taking too much time. But I'll just let you guys read through that. So a 30-year-old pregnant lady, she's at 22 weeks gestation and she presents with dysuria. Her urine, this dipstick is positive for leukocytes and nitrites, and you just have to put the most appropriate antibiotic. So let me just see if I can actually make this work. In Venice, people can also just put things in the group chat if they're happy to as well. I'll just cover it in about a few seconds.
Any problems, Anita? I'm happy to make the poll for you.
Real. I think it's gone through. But let me know if there's any issues.
Oh yeah, it has. Brilliant.
Yeah, cool. Yeah. I'll just give that a few seconds. Real. Okay, thank you for everyone who's answered, and we'll just quickly go through it. So in this case, it would be nitrofurantoin, just because this lady is not yet in her 3rd trimester, she's only in her 2nd, and nitrofurantoin is preferred to the other antibiotics to treat UTIs, lower UTIs in general. So well done to everybody who put B. Okay, on to the next question. So a 26-year-old female presents with fever, rigors, vomiting, and right-sided flank pain. Her blood pressure is 88/60. Her temperature is 38.4. Which finding most strongly suggests that this patient in particular, will require IV antibiotics? Charlotte, do you mind actually putting the poll into the group chat, just because I'm finding it difficult to just like type it up and also monitor the chat. Thank you. That's great, thank you.
No problem at all.
Really, so a lot of people got it. So it is D, just because if we go to the NICE guidelines, having symptoms of shock such as low blood pressure is an indication that patient really needs to be in hospital. Brilliant. Okay, so moving on to the next. A 79-year-old man has a long-term catheter with cloudy urine, but has no other urinary symptoms or systemic symptoms. What is the most appropriate management? Okay, bro. Yeah, so the answer for this question is C. Because this patient is catheterized, we're expecting them to have asymptomatic bacteriuria, and cloudy urine is an indication of having bacteria in the urine. However, if he has no symptoms of an actual infection, then there's no need to give antibiotics. But we would replace the catheter just to reduce the chances of infection occurring in the future. Okay. I think we've just got 4 more questions left. So 42-year-old lady presents with frequency and dysuria. Her dipstick is positive for nitrites, and she has an eGFR of 38. Which antibiotic is the most appropriate?
That's so helpful. Thank you, Anita.
No worries, sorry. You're faster than I thought you'd be.
I'll make question 5 while you do that.
Okay. So the answer for this question is B, trimethoprim, because this patient has an eGFR of 38, so nitrofurantoin would be contraindicated, and trimethoprim is the next first-line medication. Okay, so the next question, 36-year-old female presents to the hospital. She has vomiting and left flank pain. She's treated for pyelonephritis, but she remains with a temperature after 72 hours of antibiotics. What complication is the most likely? This one is a little bit harder because I don't think I specifically touched on it in the presentation, but if you happen to know it, then that's great. So the answer to this question is A, a renal abscess, which is a collection of pus in the kidneys that isn't able to be touched by the antibiotics, essentially. And this is actually quite good to know because in exam questions, the way that abscesses will usually present, or a renal abscess in particular, is a patient will have a fever despite being treated appropriately for the infection that they have. So it's a good complication to keep in mind. Just 2 more questions to go, I think. A 52-year-old man has BPH. He presents with dysuria, frequency, and suprapubic discomfort. He is systemically well. His dipstick shows leukocytes, but is nitrites negative. What is the most likely explanation? Okay, so the answer to this question is actually E, which is an infection with non-nitrite producing organism. Although E. coli is obviously the most common pathogen, there are other pathogens that can cause UTIs that don't actually convert nitrates to nitrites in the urine. The reason that it's not pyelonephritis is because he doesn't really have any symptoms relating to a kidney infection or a systemic infection. He doesn't have a fever or renal tenderness or any nausea and vomiting. He's systemically well. So we definitely think he has a lower urinary tract infection. And the abscess of nitrites does not mean that he doesn't have a UTI. It just means that it might be a little bit less likely, or he has an organism that doesn't actually produce nitrites. I hope that makes sense. That was a little bit more difficult. And the last question is, a 52-year-old man has fever and dysuria. He's diagnosed with prostatitis. What antibiotic is the most appropriate? Okay, we'll just quickly talk through this one. So the answer is C, just specifically because quinolones are the first-line medication in prostatitis. So yeah, I think those are all the questions done now. I hope that was useful. If anybody has any other questions, please put them in the chat and we'll try and answer them. But yeah, that's urology done.
Perfect, Anita. Thank you. Can you see my slide still?
Yes, we
Yeah,
can.
I can at least, yeah.
Perfect. So I'm now going to talk about HIV and opportunistic infections. On some of the slides, I have gone into a bit too much detail on HIV. For example, like the structure. You don't necessarily need to know this for exams, so I might just skip over these slides because I've got some questions I want to go through on opportunistic infections at the end, which will be a lot more helpful, I think. Can everyone? Yes. So before we start, I just want to talk about HIV in the media. So the left picture is from a advert in 1987, essentially talking about how AIDS was a death sentence, and essentially being diagnosed with HIV in the 80s, it was, whereas now, with the correct treatment regimes, patients can live long, healthy lives, and actually the stigma is more damaging than HIV itself. So HIV is a RNA virus. It's a retrovirus, and it essentially damages the immune system by attacking CD4 T lymphocytes. So there's two main types of HIV. There's HIV-1, which is the most common, and then HIV-2, which you can find in West Africa. It progresses more slowly and it's less transmissible. So transmission of HIV is via unprotected vaginal, rectal, or oral sex. Also vertical transmission, so from mother to baby, and in mucous membrane, so blood, open wounds, exposure to infected products, and also needles, sharps, splash in the eye, and things like that. So before I talk about seroconversion, I'll talk about some of the risk factors. So the main risk factors are certain sexual behaviours, so unprotected sex, multiple partners, chemsex, for example, in terms of high risk sexual practices. And we can also talk about risk factors in terms of patient populations, so MSM, IV intravenous drug use as well, people in prisons or enclosed spaces, and also from countries of high diagnosed seroprevalence as well. And there's also other exposures, so infected blood products, although it's rare to see this in this age. So seroconversion, this is the period in which the body develops antibodies against HIV, and it's usually 1 to 3 weeks post-infection. And it's symptomatic in 60 to 80% of patients. And there is actually a link between the severity of seroconversion symptoms and prognosis. So the worse a patient's symptoms are in the seroconversion stage, the poorer their prognosis. And symptoms you want to look out for in your exams is sore throat, lymphadenopathy, malaise, myalgia, and arthralgia, diarrhea, and then there's a characteristic maculopapular rash. They like to ask that in exams, and also mouth ulcers. So ways it's not transmitted. Famously, people used to think sharing a toilet seat or shaking hands could spread HIV, but it cannot. Also, just a quick comment, when you're treating patients, when you're taking bloods from a patient who is living with HIV, you don't need to double glove. I think it's such a misconception, if that's the right word. You don't need to double glove. You should be taking the correct precautions for all patients. So diagnosis of HIV. So first line, it's the 4th generation test, also known as combination HIV antibody and antigen test. So it detects both HIV-1 and HIV-2 antibodies, and these usually develop at 4 to 6 weeks post-infection, and 99% of people who have been infected with HIV will develop these antibodies by 3 months. And then the P24 antigen is a protein produced by the HIV virus in early infection, so that is quite a good marker. If this combined test is positive, it's then repeated to confirm a diagnosis. It does have a 45-day window, so this means that it can take 45 days after exposure to the HIV virus for the test to turn positive. There's also a rapid point-of-care test, which patients can buy, and it gives results in just a few minutes, but that window is 90 days. Okay, and then you can also measure HIV viral, RNA viral load, and this essentially measures the amount of virus in the blood. And this is really good in acute infection because sometimes antibody antigen tests might be negative, for example, in that 45-day window. So further investigations of HIV, so you can do the HIV confirmatory test if a patient's combined test is positive. So this allows you to differentiate whether it's HIV-1 or HIV-2. You can do the CD4 count, and this is a really, really good indication of immune function. So usually our CD4 is over 500, but in HIV, you can see it can dip below this, and it can go even below 200, below 50, and we'll talk about this in a moment. And you can also do resistance testing as well. So this is performed prior to starting antiretroviral therapy because there's some drug-resistant strains of HIV, and that can impact the efficacy of treatment. And also, if you work in MFT, you might notice that there's opt-out testing. So everyone who goes through ED is tested for HIV, Hep B, and Hep C, and that helps reduce stigma and identify undiagnosed cases and also get early treatment. So I have got sort of a picture of the structure of HIV. Everyone will have access to the slides, so you can just go back to this. I've also discussed the life cycle, but for time purposes, I'll move on. It's quite good to know the life cycle because the antiretroviral drugs target HIV at different stages of the life cycle. So HIV is managed with highly active antiretroviral therapy or HAART therapy, and it's usually a combination of at least 3 drugs. So usually 2 nucleoside reverse transcriptase inhibitors, and then one of an integrase inhibitor, a non-nucleoside reverse transcriptase inhibitor, or a protease inhibitor. It is quite a mouthful, all of the HIV drugs. I think for exam purposes, you don't necessarily need to know this, but it's always good to refer back to. So again, they affect different stages of the life cycle. So every single patient who is diagnosed with HIV should be started on antiretroviral therapy, regardless of their CD4 count. So this could be seen in an exam question, for example, a 26-year-old male, he's just been diagnosed with HIV and his CD4 is over 500. So we'd classify this as quite a good CD4 count, but this patient should be started on antiretroviral therapy regardless. And then a lot of HIV drugs are in fixed dose combinations. For example, Biktarvy and Simtuza, these are quite common drugs in HIV. And that allows patients to take less drugs, less pills, and improves adherence. There's also a lot of interactions with HIV drugs. So in clinical practice, it's good to use HIV drug interactions, but you don't need to know this for exams. Okay, so additional management of HIV. So this is quite a high yield fact. So we use cotrimoxazole or Septrin prophylactically in patients if their CD4 is low, so under 200. And this protects against pneumocystis jirovecii pneumonia, so PCP or PJP. And this is the most common, one of the most common opportunistic infections in patients living with HIV. We also offer statins if the patient's over 40 with a Q risk of over 5%. So in immunocompetent patients, we offer statins if their Q risk is greater than 10%, but it's lower than this in patients, people living with HIV. We also offer yearly cervical smears because HIV increases the risk of HPV and cervical cancer. And then also offer patients up-to-date vaccinations, so a yearly influenza, pneumococcal, HPV, Hep A and B. And we also avoid giving live attenuated vaccines to people living with HIV, so BCG and typhoid. And that's because they can get quite bad reactions from these live vaccines. So quickly, I'll just touch on PrEP and PEP. So PrEP is pre-exposure prophylaxis, and it's taken before sex to prevent HIV. It's free on the NHS for those eligible, but you don't need it if your partner's on a ART regimen and they have an undetectable viral load. So U equals U. So if the viral load is undetectable, you cannot transmit HIV. And then post-exposure prophylaxis is taken as soon as possible within 72 hours after contact with HIV. And first line is Truvada and raltegravir. And it's a 4-week treatment course. And then the patient is then tested for HIV at 12 weeks. So you might be thinking, why are we not doing 45 days? Because that's the window for combined testing. So we actually do a bit longer at 12 weeks because you can then test for different STIs like syphilis. Okay, and it also reduces the transmission, the risk of transmission, infection by 80% as well. Again, it's always important to remember that PrEP does not protect against STIs, so always advise patients to use barrier protection anyway, and regularly test for STIs. So I don't necessarily know if you need to know this for exams, but essentially to prevent vertical transmission risk, you can offer ladies to have C-sections. If their viral load is undetectable, so less than 50 copies, patients can have a normal vaginal delivery. Over 50 copies, you might consider a cesarean. Over 400, then a cesarean is recommended. And then you can also give prophylaxis to fetuses, depending on whether it's low risk or high risk. And again, this is usually if you just look at the mother's viral load. So HIV can actually be transmitted in breastfeeding as well. So for mothers on a ART regime with a sustained undetectable HIV viral load, the risk of transmitting HIV through breast milk is less than 1%. So it really depends on the mother. So monitoring, patients are monitored very closely every 4 to 6 months in HIV clinics. Their CD4 count is always checked. So the normal range is 500 to 1200. Less than 200, there's a risk of opportunistic infections. And these are infections where in immunocompetent patients, organisms won't necessarily cause disease, but in patients with compromised immune systems, so patients living with HIV, they can get quite ill from these organisms. Again, viral load is also checked. So this just checks the amount of HIV in the blood. And there is a campaign of U equals U, so undetectable is not transmissible. So whilst we can't cure HIV, with adherence to medications, patients can live long and healthy lives with an undetectable viral load. And actually, there's some evidence to suggest that patients have a better life expectancy because they're so closely followed up in clinics, and their comorbidities are also really well managed, for example, cardiovascular risk. Again, always advise barrier protection as well. So opportunistic infections. So acquired immunodeficiency syndrome, or AIDS, it occurs when HIV goes untreated, and it leads to a low CD4 count and immunosuppression. Usually we prefer to use terms like advanced HIV or end-stage HIV as well. So again, opportunistic infections are infections caused by organisms that don't usually cause disease in immunocompetent patients. And I've got a list here, but I'll go on to talk about some of the common opportunistic infections. So with a CD4 of 200 to 500, you might see oral thrush, secondary to Candida albicans, shingles, secondary to herpes zoster. You can have hairy leukoplakia, secondary to Epstein-Barr virus, and Kaposi sarcoma, secondary to human herpes virus 8. It's also important to remember that some patients, their first presentation of HIV might be actually an opportunistic infection. So they might not have gone to the doctors in their seroconversion phase. They might not have had many symptoms, but actually they might have presented with an opportunistic infection. So if you see any patients with these, then do consider just doing a HIV test. And then we have other opportunistic infections as well. So 100 to 200 CD4, you might see cryptosporidiosis, toxoplasmosis, PML, HIV dementia. And then 50 to 100 aspergillosis, esophageal candidiasis, cryptococcal meningitis, and CNS lymphoma. And then less than 50, you can sometimes see CMV retinitis. And this is actually quite common. So 30 to 40% of patients who have a CD4 less than 50 have CMV retinitis. And then you can also see Mycobacterium avium complex. So there's some AIDS-defining illnesses, so Kaposi sarcoma, PJP, CMV retinitis, candidiasis, lymphomas, tuberculosis, and toxoplasmosis as well. So I'll go into discuss a few of these. So these are the ones that you might be more likely to see in exams. So Kaposi sarcoma, it's a soft tissue sarcoma affecting the skin and mucosa. So you can see it in the GI and respiratory tract. It's caused by human herpes virus 8 and it affects more men to women. And it's characterized by these purple papules or plaques, and they can also ulcerate if they're nodular. Patients might also have fever, weight loss, and fatigue. And it's diagnosed with biopsy. You can also do chest X-ray, CT, or endoscopy for GI or respiratory involvement. And it's usually managed with radiotherapy, resection, chemotherapy, or and combination antiretroviral therapy. So really, you want to try and reduce the chance of patients getting opportunistic infections by establishing them on antiretroviral therapy and monitoring them in clinic. Okay, so PJP is the most common opportunistic infection in advanced HIV, and it's a fungal infection with pneumocystis jirovecii. So again, all patients with a CD4 of less than 200 should receive Cotrimox. It has quite non-specific features, so patients present with shortness of breath, a dry cough, fever, and it's managed again with cotrimoxazole, that's spelt wrong, and IV pentamidine in severe cases. And to investigate, you do chest X-ray. Characteristically, patients, especially in exam questions, I'm not sure clinically, but in exam questions, the patients always seem to have exercise-induced desaturation. So if you see on an exam question, a patient has come to you and their oxygen stats are 97%, and then on exertion or when they walk, it goes to 93 or 92, then you want to consider PJP pneumonia. And then on bronchoalveolar lavage, you can get cysts on a silver stain. And then if anyone's had ID, you might know that beta-D-glucan is a good marker of fungal infections, but it's not very specific. So CMV, it's a member of herpes virus. 50% of the population is exposed to CMV, but it only really causes disease in immunocompromised patients. And with a CD4 of less than 50, patients are at risk of something called CMV retinitis, and it affects quite a large population of patients who have a low CD4 of less than 50. And it's characterized by a blurred vision, and on fundoscopy, you get retinal hemorrhages, and it's sort of sometimes called a pizza retina. I don't think it looks like a pizza, but you can judge that. And it's treated with IV ganciclovir. And you can also get CMV-related encephalopathy, colitis, and pneumonitis. Again, always think in an immunocompromised patient with painless progressive visual loss, consider CMV retinitis. So we're going to talk about the neurological complications. A lot of the neurological complications of HIV present quite non-specifically, usually with headache, fever, altered mental status, focal neurological signs, and meningism. But it's important to diagnose correctly so you can start the correct treatment. So one of the most common ones and well-known ones is toxoplasmosis, and it's caused by parasite Toxoplasma gondii. And this causes 50% of cerebral lesions in people living with HIV. And it can be found in meats, famously cat feces, and also contaminated soil, and it causes an encephalitis. So this is quite a high yield fact. So on MRI or CT, you get multiple ring enhancing lesions, and the thallium spect is negative. So as you can see here, These are ring enhanced, so it has that white ring around it, and the middle is an abscess, and essentially it's necrotic in the middle. And then this is a prophylaxis and management as well. So CNS lymphoma, this accounts for 30% of cerebral lesions in people living with HIV, associated with Epstein-Barr virus, and characteristically it's a single homogeneous enhancing lesion. So you might only see one or a few, and it's all the same colour, whereas in toxoplasmosis you have the ring enhancement and the necrosis in the middle. And then the thallium spect is positive because lymphoma has a high uptake. So there's progressive multifocal leukoencephalopathy. This is quite rare and it's caused by JC virus, and you get progressive widespread demyelination. So in the question, a patient might have a sort of weak history of hemiparesis, visual defects, dysarthria, and impaired mental status. So it happens over time. It's not very acute. And on MRI, you get multiple non-enhancing white matter lesions without a mass effect. And it doesn't enhance with contrast. It's quite difficult to manage. Essentially, you just want to optimize the antiretroviral therapy to restore immune function. And then we've got cryptococcal meningitis. It's the most common fungal infection of the CNS, characterized by headache, fever, malaise, nausea and vomiting, seizure, focal neurological deficits, and meningism. And on CSF analysis, you get the fungal picture. So if anyone's attended the session 1, we went through LP interpretation. Essentially, in fungal infections, you'll get a high opening pressure, raised protein, reduced glucose, a normal lymphocyte count, but it can be normal in HIV. And then the India ink test is positive. And on a CT, you get meningeal enhancement and cerebral edema. And this is just the management. So key points: don't stigmatize patients, treat patients with HIV as you would any patient. And I know this isn't very exam focused, but I do think it's very important. So use less stigmatizing language. So instead of HIV positive, use person living with HIV. Instead of AIDS, use advanced HIV or advanced disease. Instead of compliant, use adherent. And then just remember, anyone could have HIV. Don't have an unconscious bias. And then always remember U equals U. So if it's undetectable, it's untransmissible. So I've got some questions to go through now. So Charlotte, I don't know if you want to just look at the chat because I can't see.
Yeah, of course. There's not anything. I was just going to ask a question though.
Yeah.
With cryptococcal meningitis, usually the thing with meningitis is you get meningism, but it's when it's encephalitis that you get the neurodeficits. Is it literally just on LP that you distinguish the two? Like it's mostly imaging and lumbar puncture?
Very good question. I assume that's the case, but I will get back to you on that.
Thank you so much.
Okay, so if we just go to the questions. So this is a 38-year-old male. He's gone to ED and he's got shortness of breath, non-productive cough. He started antiretroviral therapy for HIV. His examination's unremarkable. His temperature is 37.7, O2 sats are 95% on room air, and he has a chest X-ray performed. So what is the most likely diagnosis? If people could just pop in the chat.
Do you want me to read answers out to you?
Yep.
We've got a first answer of PCP.
Yep. Yeah, so that's perfect. It is pneumocystis Jirovecii pneumonia. So it's always important to look at the patient's history because a chest X-ray might be unremarkable. It might just show a typical pneumonia. So the patient has HIV, they've got chest symptoms and normal examination findings. Always remember a patient with PCP or PJP might have desaturations as well if they stand up and move around. Okay, so this is a 42-year-old male with HIV, and he has regular CD4 counts, and he's on ART. So 4 months ago, his CD4 was 467, which isn't too bad. It's below 500, but not awful. And his CD4 count today is 145, so quite low. He feels well in himself, and there's no evidence of any AIDS-defining illness. So his doctor is concerned about the risk of PJP, pneumocystis jirovecii infection, and considers a need for prophylaxis. So what's the most appropriate management plan, do we think? So we could just continue his medications and don't give him anything. We could start his Cotrimox if it's below 100, start it now, start Pen V, and start what I presume is an antifungal. So what does everyone think?
I'll let you know when there's an answer in the chat, but just one for you to think about as well. We've got a question of if you've got a typical pneumonia and a low fever with a history of HIV, how can you say that it's PJP instead of a normal strep pneumonia? Is it purely numbers, like it's a sort of statistical probability?
I think statistically, it's the most common opportunistic infection in patients with HIV. So you always have to suspect it, and I suspect that they would give Cotrimox anyway to treat as a PJP. I'm not too sure on that.
It's safer to assume it is than
It's safer to assume
leave
it is,
it, isn't it?
definitely, because even with patients with I mean, what this question suggests, with a low CD4, you would want to okay, yeah. So you start Cotrimox. So patients with a
That's what all your
CD4.
answers were here as well. You got a load of answers in the chat for that.
Okay, perfect. Well done, everyone. So yeah, always suspect PJP in patients with people living with HIV who present with a sort of pneumonia picture. I guess you can also do the investigations like the bronchoalveolar lavage as well, but I think they would probably start on Septrin. Okay, so a 20-year-old male presents to GP with 1 week of fever, myalgia, sore throat. He returned from a business trip to Thailand 4 weeks ago. He's got a widespread maculopapular rash and tender cervical lymphadenopathy, and he's febrile as well. So what do we think is the most appropriate initial investigation to confirm the diagnosis? Oh, sorry, I've not put the investigations. So do you want to do dengue virus, antigen test, Epstein-Barr virus serology, a combined HIV test, blood cultures, or measles IgM serology?
You've got some answers of C, combi test.
Yes. Perfect. So we want to do a combined HIV antibody and P24 antigen test. So this man is a returning traveller. He's got seroconversion symptoms. So specifically the maculopapular rash. He's got lymphadenopathy and he's febrile. And again, just a reminder, the combined tests can detect HIV 2 to 4 weeks after exposure. But again, remember the 45-day window. So if a patient is negative in that 45 days, you might want to just retest them after 45 days. Okay. So 40-year-old patient reviewed in neurology clinic after suffering a seizure. Past medical history of HIV. He's had a brain CT which shows a single lesion with homogeneous enhancement and a positive thallium SPECT. So what do we think is the most likely cause of this patient's symptoms?
Do you want to put the options up, lovely?
Oh, sorry. So we've got we've got Cryptococcus, CNS lymphoma, CNS tuberculosis, HIV encephalitis, or toxoplasmosis.
Got a few answers come through of B, CNS lymphoma.
Yes, perfect. So the patient has HIV and neurological symptoms. Characteristically, they have the single homogeneous enhancement on CT and positive SPECT. So lymphoma has high uptake on thallium SPECT. Yes, I think a lot of the time it's easy to confuse CNS lymphoma and toxoplasmosis. But if you just remember that toxoplasmosis is ring enhanced and negative SPECT. But well done, everyone. So I think this is our final question before we just go on to peds. So this is a 30-year-old man who's an immigrant from Albania. He's been unwell for a number of months and he's lost 8 kilograms and has chronic diarrhea. And this is seen on his skin. He also has lesions like this inside his mouth. So what do we think is the most appropriate action? So we can give benzyl penicillin, phone 999. We can do a chest x-ray, order a HIV test, start vitamin C, or order hepatitis C test and cryoglobulin screen. So first of all, what does this look like? And what may we want to do if we suspect this?
You've got a few people asking, could this be Kaposi sarcoma?
Perfect. So it's this characteristic sort of papules on the skin. And also there's involvement in the mucosa. On one of my placements, I saw a patient with Kaposi sarcoma, and it is very like the widespread like papules on the skin is quite characteristic, and you can also see it in the mouth, in the oral mucosa. So you want to do a HIV test because it is an AIDS-defining illness, a sign of advanced HIV. So even though this patient hasn't been diagnosed with HIV before, this could be their first presentation. Okay, so I don't know if we've got time for questions, but if anyone wants to put anything in the chat, I'll try and answer them. And then we have our final section on paediatric infections. So Lydia, do you want to just share your screen? I'll stop sharing now.
Yeah, I'll just try and share it now, sorry. Sorry, I had a bit of trouble doing this before. Hopefully it'll come up okay. Share. Is that working okay?
Yeah.
Oh, it's gone all the way, hasn't it? Let me just get to the slide. Sorry, 1 second. Is that coming up now?
I'm still on the first slide. I don't know about you guys.
I'm still on the first. Oh wait, no, I'm on it.
Yeah, now we're at peds
Perfect.
infections.
Brilliant. All right, Okay. My name's Lydia. I'm going to be covering paediatric infections. So let's go on to the first one. So I've just listed out. Oh, is that not changing? There we go. So I've just listed out some of the conditions we're going to cover today. We'll just run through them. So we're going to start with chickenpox. So I've started with a few facts about them first. So it's spread via respiratory droplets and direct contact with the vesicles. So as in touching somebody that has chickenpox. It's caused by the varicella zoster virus, VSV. People are infectious 48 hours before the rash and also until all of the lesions crossed over, after which point they are actually no longer infectious. Typical incubation period is around 2 weeks, specifically 10 to 12 days. One of the most characteristic things of chickenpox and the diagnostic hallmark is the lesions being at different stages. Let's put the picture up as well. Here we go. So generally you'll see some papules, some vesicles, and some that are crusted over, and that is characteristic of chickenpox. So it can be used for clinical diagnosis, which is the main form of diagnosis as well. So mostly clinical opinion, and we only PCR in those that are high risk. So neonates, babies, immunocompromised, and pregnant women. So the initial presentation starts with a prodrome. So you've got fever and malaise beforehand, and then it develops into the itchy rash, starting on the trunk and then typically spread into the face and scalp as well.
In terms of prevention, so chickenpox is notifiable in Scotland and Northern Ireland, but not the UK, not in England, sorry. There's no mass vaccination in the UK, and in terms of school exclusion, it's until all of the lesions crossed over, because after that point, they're no longer infectious. And then we've got management. So typically, in most cases, it's just going to be supportive. So paracetamol for the fever, hydration, lots of water, and helping them to avoid scratching as well. A really good one to know for exams is also to avoid NSAIDs. So chickenpox and ibuprofen, there is a risk of necrotizing fasciitis. So that's one to watch. And then sometimes I've just put this here as well because I'm covering peds today, but just in terms of teenagers and adults, sometimes we might use oral acyclovir as well, but that's only used if they present within 24 hours of rash onset. Next. I've just put a few extra points to remember here as well. So in those who are immunocompromised, we want to always seek urgent specialist advice, and acyclovir is considered as well. We've also got IV immunoglobulins, are also considered in those that have never had exposure before, so i.e. never had chickenpox as a child. Some important complications to remember. So typical secondary bacterial skin infections are probably going to be the most common, so impetigo and cellulitis. And then we've also just got some exam points here as well. So viral pneumonia in older children and teenagers. Just put this one here about NECFAC again with the NSAIDs. And then also Ray's syndrome. So Ray's syndrome, I put a little picture up here. So it is very rare and it's generally seen in kids and young adults recovering from viral illness. And we believe it is linked to aspirin. So that's another one to avoid in chickenpox. So ideally, we want to be telling patients to take paracetamol and avoiding aspirin and ibuprofen. I've just put here as well a couple of neonatal red flags. So in maternal varicella, 7 days before delivery to 2 days after, there is a risk of severe neonatal varicella. So we're going to give IV acyclovir and Vizig as well. And then I've just mentioned shingles too. So contracting chickenpox, there is a long-term risk of shingles, essentially from reactivation of the VSV virus. And that occurs with, previous chickenpox infection. Croup. So croup is viral inflammation of the upper airways leading to subglottic edema and narrowing. So if we look here on the photo, this area here, so subglottic, we get swelling around this area, causing the pipe to narrow. So typical presentation is 6 months to 3 years old, and it's often worse at night. Typical way to know to spot it in an exam, is the barking seal-like cough. And then we also see hoarse voice and fever and typical coryzal symptoms, so snotty noses and coughs. In terms of signs, so all the typical signs of respiratory distress, so inspiratory stridor, subcostal recession, sternal recession, all of our typical ones for respiratory distress in peds and babies. In terms of the cause, so mostly it's parainfluenza, so that's going to be the one we pick on a multiple choice exam, but other causes as well can be influenza, RSV and rhinovirus. In terms of management, so in mild croup, we're just going to give a single dose of Dex, and then that can be repeated after 12 hours if needed. In terms of moderate to severe cases, we want to give Dex and nebulized adrenaline, and oxygen will be considered depending on stats as well. I've just put here as well, make sure to keep the child calm. So stressing them out and trying to do lots of examinations is obviously going to worsen airway obstruction. So keep them calm, sit them with parents, everything like that. Whooping cough or pertussis. So it's referred to as the 100-day cough due to its slow resolution. So whilst they're not infectious for all of this time, coughing fits can persist up to about 3 months, hence the name 100 days. It's caused by Bordetella pertussis, which is a gram-negative bacteria, and referred to as whooping as well because it's the classic gasping in afterwards. So the coughing fits are normally so severe that essentially the child struggles to breathe afterwards. So they create the classic like whoop sound, the sucking inwards after they can finally breathe in. And this is a notifiable disease as well. In terms of presentation, so the first 1 to 2 weeks will just be a mild dirty symptoms, but this is the most infectious phase. And then 2 to 6 weeks, this is when we're going to get our severe bursts of coughing, the classic inspiratory whoop sound, and then vomiting after coughing fits as well. This is also where we see apnea in infants, which is a very key red flag. So parents saying that babies are stopping breathing after coughing fits as well. In terms of diagnosis, so we want to do PCR testing, and that can be confirmed in the first 3 weeks of infection. And management, so typically very unwell patients, particularly babies, are going to want to be admitted. Teenagers and older children will be off school until they have either taken 48 hours of antibiotics or 14 days from the onset of the cough. Antibiotics, so they can be given within 2 weeks of onset, and then also we can give prophylactic antibiotics to people that are high risk. Sorry, got a bit of a cough myself. Scarlet fever. So in terms of the classic presentation, so I've just popped some pictures down here. We've got fever and sore throat, the sandpaper rash, which we can see down here, which typically starts on the trunk and then spreads outwards to arms, face, rest of the body. And then here's the classic strawberry tongue as well. In terms of other key features, yeah, so just starting on the trunk, spreading out to the hands and feet. This is one that came up as well in exams, so Pasteur's line. So essentially it's a rash that's seen in skin folds, so around the groin, potentially in like elbow creases and things like that as well. And then we also get a pale area around the mouth there with the classic flushed cheeks too. And that rash typically appears 12 to 48 hours after the onset of the fever. So it's caused by group A strep typically, and often does occur following tonsillitis. It is notifiable, and parents need to keep them off school until 24 hours after starting antibiotics. And the management is penicillin V, just like we use for group A strep typically, and bacterial tonsillitis, and then clarithromycin if penallergic. Okay, just put a few other key facts here as well. So in terms of risks, we do have untreated infection has a risk of acute rheumatic fever, which in itself is a post-strep autoimmune reaction, which essentially causes inflammation of the heart, joints, skin, brain tissues as well. And that's typically seen 2 to 4 weeks after a group A strep infection. So that actually could be with tonsillitis and other things as well, but it is a key one to know as a risk with scarlet fever. Diagnosis, yeah, so it's normally clinical. Go back a slide. So these are very key symptoms. So the fever, sore throat, the rash, and the strawberry tongue is what normally tells us it's scarlet fever. So typically based on clinical presentation, and then we can also do a throat swab for group A strep. Measles. So caused by the measles virus, spread via droplet infection, and it is extremely contagious and hence a notifiable disease. So in terms of our presentation, so we get the prodrome. So we've got cough, fever, coryza, and conjunctivitis. This is a really key one to remember. It comes up in exam questions a lot. Most people have probably seen it on PassMed. And then also we've got the pathognomonic Koplik spots. So that's the white dots seen here in the mouth, on the buccal mucosa. And essentially, if a patient has Koplik spots, you can automatically diagnose measles. It's pathognomonic, so completely indicates it. And in terms of rash development as well, so it typically starts behind the ears, 3 to 5 days after the fever, and then spreads onto the body, which we can see here in the rash. Macular rash with flat lesions. Okay. The reason why measles is so important is due to the complications. So 30% of patients are going to develop a fairly severe complication. So pneumonia, severe diarrhea to the point of needing fluids, otitis media, dehydration, encephalitis, meningitis.
and also hearing loss and vision loss as well. That's one that typically comes up in exams as well. This was just one to note. I don't know how high yield this would be for exams, but SSPE is one to know essentially. So it's a fatal disease that can occur 7 to 10 years after infection with measles, and it essentially presents with behavior change and seizures years afterwards. Mumps. So caused by the mumps virus. It replicates in the upper airway and then spreads to the blood via parotid glands and other organs. And obviously it's spread person to person by droplet infection. So presentation is going to be parotid gland swelling. So we often see bilateral swelling around the neck and face area, so just around here. Earache and pain when chewing, and then the typical fever, headache, and malaise. Diagnosis, so clinical, but we can confirm via salivary swab as well. In terms of management, generally self-limiting, so most kids recover in 1 to 2 weeks, supportive management, and no school for 5 days after the swelling of the parotids. Complications, so orchitis in 25% of post-pubertal males, so teenage boys, complications after mumps, think orchitis. Then we've also got meningitis and Riley encephalitis. And then just here showing the position of the parotid gland. So that's why we get the typical swelling around the face and neck. Sometimes it's referred to as the hamster face appearance as well due to the swelling of the cheeks. Rubella, the German measles. So again, viral infections spread via droplets. It is actually now eradicated in the UK and there hasn't been any cases since 2019, although it was actually quite common before the MMR vaccine in England. All suspected cases of rubella are going to be notifiable. Generally, so 25 to 50% of patients are actually asymptomatic, especially the young children, although they can present with low-grade fever, typical viral symptoms, and then a pink maculopapular rash with lymphadenopathy. Again, it's quite important to know where these rashes start and progress because it's an easy way to identify them in questions. So the rash starts on the face and then spreads downwards, whereas before we had it starting on the trunk and then, where has it gone? And spreading outwards in measles. If I got that there, yeah. And then just want to know about as well, so we've got congenital rubella syndrome, which if infection with rubella occurs in the first trimester in mum, there is a very high risk of sensorineural deafness, cataracts, and heart defects in baby. Bronchiolitis and RSV. So bronchiolitis is essentially viral infection of the lower airways, which is almost always caused by RSV. So whilst they're not the same condition, bronchiolitis is mostly caused by RSV. So sometimes they can be interchangeable in practice, although they're not exactly the same. RSV is the cause of bronchiolitis. In terms of age, so we typically see it in patients less than 12 months and typically seen in those 2 to 6 months. So we're thinking small babies. And then again, typical signs and symptoms are going to be the respiratory distress ones. So raised respirate, accessory muscles, intercostal and subcostal recessions, flaring, head bobbing. All of these things are ones that you definitely need to know for OSCEs and clinical practice as well. So definitely learn these ones. In terms of presentation specifically for bronchiolitis, so we've got coryzal symptoms in more milder cases, so runny nose, sneezing, watery eyes, heavy laboured breathing, fast breathing, and also reduced feeding is a good one to look out for. So typically we're going to be asking mums about are they taking less than 50% of their bottle? Are they taking less than 25% of their bottle? Are they having reduced amount of wet nappies, indicating that they're not drinking as much? And then in terms of other symptoms, so mild fever and apneas and cyanosis when very low oxygen sats. Admission criteria, this is one to particularly learn. So if baby's under 3 months, we want to admit straight away. If they've got pre-existing conditions, so heart defects, other things like that, we want to admit. Less than 75% of their daily fluid intake. So again, that's why it's so important to ask about bottles. Reduced wet nappies, reduced urine output, O2 under 92%, and then any signs of severe respiratory distress. So this one here is one to learn exactly, as it comes up on PassMed quite a lot and will do in finals. In terms of management, so again, we want supportive, so ensure good intake of fluids and feeds. Nasal saline drops and suctioning is quite common. Oxygen if sats are below 90, 92 if very high risk. And then may be necessary to check CAP blood glucose as well. Yeah, and we've also got medication as well we can give to babies that are particularly high risk, which is a monthly injection given to them essentially to help prevent RSV. There is a vaccine that's available for mums during pregnancy. So the RSV vaccine is given from 28 weeks, and this provides protection for baby for the first 6 months of its life, which is obviously the peak onset as well, which is about 2 to 6 months. Hand, foot, and mouth. So we've got presentation. So typically prevents with common viral infections, so mild fevers. And then in terms of the rash, so we've got the classic presentation of vesicles on the hands, feet, and mouth. These are often very painful as well and can be seen on the tongue and inside the mouth too. So it's generally caused by the Coxsackie virus, and the management is supportive only. Although it is very highly contagious, and patients must be warned about this as well. So avoiding sharing towels, cups, things like that. Diagnosis, again, because it's so typical within lesions on the hands, feet, and mouth, it's going to be clinical diagnosis. And complications are actually quite rare, but may include things like what we spoke about before with chickenpox, so bacterial infections from scratching at lesions, and then more severe things will be encephalitis and dehydration. Slap cheek or fifth disease. So in terms of presentation, so phase 1, we get mild viral symptoms, low-grade fever, coryzal symptoms, everything like that. Phase 2 is where we see the typical slap cheek appearance, so redness and raised lesions on the cheeks. And then in phase 3, have I got a picture? Yeah, here. So we get this lacy reticular rash. That's one to learn too. That's come up quite a few times on PassMed. And it may come and go with heat. So often when children like exercise and get hot, you can see the rash appear, and then it may go away at rest. Management, so supportive, and there's also no need to exclude from school once the rash appears, because once the rash comes up, they're actually no longer infectious. The only thing to watch out for here is telling parents to get their children to avoid any pregnant women, because that does come with higher risk. In terms of complications, so in sickle cell, aplastic crisis is one to watch out for. We've also got hydrops fetalis as well, which is a life-threatening condition where the fetus develops widespread and severe edema, which is why we need to be careful that children aren't going around pregnant women if they're infected. Sixth disease or roseola infantum. So it's a viral infection caused by human herpes virus 6. Again, this one's done on clinical diagnosis. Generally, they present 1 to 2 weeks post-infection with the classic rash seen here. The rash actually appears after the fever resolves. So generally, patients will stay at home and then present once they get the rash, although they're no longer infectious at this point. It's not similar to other ones in the sense of it's not actually itchy, so it's essentially just small pink and red spots across the skin. And again, this one starts on the trunk and spreads to the neck and arms. Generally, children with sixth disease are actually fairly well. It only lasts for a couple of days and they shouldn't need too much management. So yeah, so supportive, no school exclusion once the fever resolves. The only main complications is going to be febrile convulsions, and then again, that's just due to the high fever that lasts for a couple of days prior to the rash appearing. Rarely there are some complications as well in immunocompromised children, but that's going to be the same as other ones we went through, so I won't go through that today. Impetigo. So it's a superficial bacterial skin infection, mostly caused by a Staphylococcus aureus, which is given its golden crust appearance. So we can see here lesions appear to be crusted over with a goldish yellow-like film, and that's typical for Staph aureus infections. It's most common in children, with the peak age being 2 to 6 years. There's actually two types of impetigo. So we've got non-bullous, which is the most common, and that's the classic golden crust, often around the mouth or nose. In terms of treatment, so topical fusidic acid or hydrogen peroxide, and if very severe, we can give oral flucloxacillin. We want to keep children off school until 48 hours post antibiotics. And yeah, this is the most common type that you'll see. And then the other type is bullous impetigo, which is very large fluid-filled blisters, which again burst to form the crusts. This is always Staphylococcus aureus, and as this one is more severe, we are going to give flucloxacillin, whether that's oral or IV, depending on the severity. And we do want to isolate these patients as well, as it is very contagious. Complications, so again, think skin infection complications, so cellulitis, and then rarely staphylococcal scalded skin syndrome as well. Ringworm or tinea corporis, so it's a fungal infection and it's spread by direct contact. The typical presentation is an annular red scaly patch. We've got the raised active border here and then central clearing. It tends to expand outwards over days to weeks, and lesions are typically seen on the body and limbs, trunk and limbs, sorry. Management, so topical antifungal once or twice daily. We've got a few options here. And then if it is extensive or resistant, we're going to progress to oral. And we do also want to avoid topical steroids as well. This is a bit of an example here. So topical steroids do actually mask the infection and can also worsen it, which is known as tinea incognito. So we always want to avoid topical steroids there. Is this the last one? Oh no, a couple more. So we've got molluscum contagiosum. So it's a viral skin infection caused by the pox virus. These are very typical lesions seen here. Essentially, they're just small, quite hard dome-shaped papules with a central dimple in the middle, like a small donut shape there. They can be itchy, not always, and the child is otherwise completely well. It's spread by skin contact, towels, swimming pools, and those with eczema or those that are immunocompromised are most affected. In terms of management, nothing, so it will resolve in 6 to 18 months on its own, but it's just one to watch out for as children may come to particularly GP with things like this. And yeah, there's no need to stay off school unless the lesions are open, which obviously puts them at more risk of bacterial skin infections as well. I have put a mention of Kawasaki disease as well. It's not an infectious disease in itself, but the reason it's been included is because we think it's likely triggered by an infection, so often common viruses and bacteria as well. What Kawasaki disease is in itself is an abnormal immune reaction which causes a widespread inflammation of the blood vessels, otherwise known as vasculitis. So we've got some typical pictures here of what we can see. And those features are persistent high fever, generally for over 5 days, widespread maculopapular rash, skin peeling on palms and soles, we can see here, strawberry tongue appearance, cracked lips, and also one to watch out for is bilateral conjunctivitis and lymphadenopathy as well, as they're quite common in Kawasaki disease. In terms of the management, it's high dose aspirin and IVIG. Just remember, it's not an infectious disease. However, we think it may be caused by infection, which is why we've noted it here. One to mention here as well, we also want to avoid aspirin in these cases as well, due to the risk of Ray's syndrome, as you spoke about earlier. Paediatric meningitis, finally. So we got both slides here. Yeah, there we go. So bacterial meningitis. So it is notifiable. We've got the common causes here. So in terms of management, so in the community, we want to do immediate IM benzyl penicillin. And in hospital, ideally, we want to do an LP, but we don't want to delay treatment. So if it's suspected, we want to treat with antibiotics. It does vary slightly depending on age of the child. So where they're under 3 months, we want to use cefataxime and amoxicillin, and over 3 months, ceftriaxone and dexamethasone. In terms of post-exposure prophylaxis for other people, so single dose of ciprofloxacin for anyone who's been in close contact with that child. Just put here the difference between the two as well, in terms of meningococcal diseases. Viral meningitis, so the cause is HSV most commonly, but we've also got enterovirus and VSV as well. So typically we want to send lumbar puncture CSF samples to PCR. Viral meningitis is typically milder than bacterial, and generally we use supportive management. However, if we do confirm HSV or VSV, we can treat with acyclovir. Just a good one to remember as well. So the differences between bacterial and viral and LP. And just a note as well, if we do see any signs of raised intracranial pressure in the child or anyone, do not do the LP. In terms of complications, so hearing loss, seizures, epilepsy, and more severe ones as well. I think we are done.
Absolutely. We just got a question from Charlotte.
Yeah,
when
yeah.
do we avoid aspirin?
So aspirin is going to be avoided generally in all conditions where we see, so all of these conditions other than Kawasaki, we're going to want to avoid aspirin.
Basically, in pediatric patients, we avoid aspirin.
Yeah, the only exception here is we got Kawasaki disease.
So basically be quite sure that it's Kawasaki before you start putting the kids on
Exactly.
aspirin.
Yeah. So generally we always want to avoid aspirin in children just due to the risk of Ray's syndrome. But yeah, Kawasaki is the only one where we do give a high dose aspirin.
Lovely stuff.
And then we have a comment from Anastasia. So just for everyone who's still on the teams. So from a dermatology perspective, for impetigo, it can be caused by Staph aureus or strep pyogenes, but it's a streptococcal version which causes post-strep glomerulonephritis. So that's a good point.
Good one. Yeah.
Okay. So that's the end of the session. So thank you everyone for coming to session 2. I have popped the feedback form in the chat. So if anyone wants to fill it out, and we'll get the slides sent out as soon as possible. And then we have session 3, our final session tomorrow, which is covering skin and soft tissue infections. So we have loads of skin examples, skin questions, which is really useful, especially with progress and finals. And then we're also covering tropical medicine and high yield antimicrobials. Yeah, so that's everything. So thank you to everyone who's attended and asked questions and interacted. And we hope it's been very useful for everyone. So I'll stay behind on the chat for a few more minutes. I think it's going to end soon anyway. But if anyone's got any questions, then feel free to stay behind or email me.
That was absolutely brilliant, you guys. Thank you so much for doing that. We are so lucky to have you guys. That was so good.
I know it's a lot of information, but it's
But you summarized it and conveyed it so well. So
thank you everyone.
Thank you.